Hello, everyone, and welcome back. This is Module 3 of Thinking Critically, Interpreting Randomized Clinical Trials. In our first two modules, we had reviewed key design features of Phase 3 randomized clinical trials and approaches for analyzing RCT data. I'm sure you're all excited to get to this particular module because in this one, we will actually see how to go about critically evaluating a clinical trial, and we're going to accomplish this in two steps. In part one, I'll walk you through the whole critical evaluation process and how to come up with the questions that can help you think critically. In part two, we will give you the opportunity to apply all of the skills you've learned now to actually critically evaluate a paper and come up with your own conclusions about the validity of the findings. Now, before I begin, I want to put this in the framework of evidence-based medicine, especially to those of you who are clinicians and health professionals. Evidence-based medicine is the integration of best research evidence with clinical expertise and patient values. And typically, EBM involves 4 steps. The first one starting with our formulating our answerable research question. And this usually comes from clinical experience, a question that you may be curious about or that a patient might pose to you. You then go about looking for the evidence, either through PubMed, UpToDate, or whatever your favorite resources might be. The third step is the critical appraisal of the evidence, and for the most part, this tends to be the most challenging step. However, it is the most critical step because based on whether we infer the study results are valid or not, we can then either move on to step 4 or just drop the paper right there. So if step 3 concludes that we do believe the study findings, then we can go to step 4, where we may think about translating the results to clinical practice. So we believe that if we teach the consumer to think critically and come up with the subset of questions that helps you answer step 3, that we can all come up with sort of a consistent answer and interpretation of a published article. So critical appraisal is a systematic process that's used to identify the strengths and weaknesses of a research article in order to assess the validity and usefulness of research findings. Now, here are the important components of a critical appraisal process. You, of course, are going to start with evaluating, what is the research question, and is this particular study design appropriate for answering that research question? Once you have done that screening and want to move on, you then have to look carefully at key methodological features of this particular study, the way it was designed, the way it was conducted, because this sheds light on the internal validity of the findings. Of course, there are other factors to consider, such as the suitability of statistical methods that were used and how they were interpreted, what are the potential conflicts of interest that the authors or researchers may have, and what is the relevance of research to one's own practice. The other point I'd really want to emphasize is that when you're critically evaluating a study, in addition to being aware of potential sources of bias that may have affected the conclusions, as a reader, you should also be able to predict what effect a given bias would have on this estimated effect that you're observing in the study. Since no study is going to be perfect, and biases are going to exist, it doesn't necessarily mean that you cannot believe the study results. So what critical appraisal involves is identifying the source of bias and then trying to predict in which direction would this particular bias affect the study results. So what do we mean by internal validity? Well, internal validity is a measure of how easily a difference in outcome between two groups can be attributed to the effects of the exposure or intervention under investigation. So simply put, these are the 2 questions I ask when I'm thinking about internal validity. 1, do we believe the results? Or could there be other alternative explanations for these findings? So bias is any deviation of truth beyond just chance or random error. And so bias is usually produced by systematic errors during the design and conduct of the study. So the way in which the investigators have done their sampling, the way they've collected the information, or the way they have analyzed and interpreted the data can all lead to biased results. So when we look at a paper and say we are looking at the study findings, if we believe that, the study results are valid, then we would assume that the study has internal validity. However, when you read a paper and you think, no, there could be some alternative source of bias that could result in this association between an intervention and the outcome, then we claim that the study is biased and there is no truth or internal validity, and we stop there. However, if we believe that the study is internally valid, we can then ask the question about external validity or generalizability. Would this apply to my patient or to the population beyond that was studied in this particular sample? So if we did our sampling right, then usually the sample we studied, the results we found there should be generalizable, and we can say that there's truth in the universe as well, making inferences from our study sample. However, if our sampling wasn't done correctly, then while the study may have internal validity, it may lack external validity. So the point to remember is that the study must be internally valid before you even think of translating this to the patient sitting in front of you or to the larger population of interest. Now, here are the 4 main common threats to internal validity: confounding, selection bias, misclassification bias, also known as information bias, and finally, chance variation. And this is the random error piece. Now, there are actually several catalogs of study biases, but I would tell you that most researchers will agree that you can bin all of these sources of bias into these sort of logical bins that I've provided here on this slide for you. Now, one thing to note is that the first 3 sources of bias here, confounding, selection bias, and information bias, are sources of systematic error. On the other hand, chance variation or sampling error is a random source of error. So let's look at each one of these. So what's confounding? Well, confounding is defined as a distortion of an exposure-outcome association that's brought about the association of another factor with both the outcome and exposure, as you see here in this little picture. So what we care about is whether the exposure is related to the outcome. However, and let's say we do see an association, what we need to wonder is, could there be these confounding factors that are also associated with the outcome? So inherently, confounders tend to be risk factors for the outcome of interest, as well as they may be associated with the exposure and may lead to a spurious association between the exposure and the outcome. So let's look at an example. Let's say I was interested in whether physical activity, particularly low levels of physical activity, increase the risk of type 2 diabetes. And let's say the study finds that association. But because people, picked their level of activity, we would really worry about age being an important confounder. And why is that? Because as we know, type 2 diabetes is adult onset. So the older you are, that increases your risk for type 2. But perhaps older people are also less likely to follow, really rigorous physical activity levels. And so even though you're seeing this elevated risk, it may not all be due to low physical activity. Some of that increased risk might be coming from increased age, because the only way to control for this is through randomization. So we are lucky because we're talking about randomized clinical trials. There are other statistical procedures that can be used to control for confounding, and you can do certain things in the design phase. But this usually is an issue for observational studies where subjects are selecting their own exposures. In a randomized clinical trial, because you're randomizing who gets the exposure, we have the ability to balance the groups we're comparing with respect to this confounding factor. So by randomizing the intervention and who gets the different levels of physical activity, for example, we can make sure that the distribution of age is similar in the 3 groups. Now let's talk about selection bias. So the classic definition of selection bias is a form of sampling bias where there are systematic differences between those who are selected for study, that is, who agree to participate, and those who are not selected, or those who get left out or refuse to participate. And the method of participant selection that distorts this exposure-outcome relationship from that present in their target population leads to selection bias. And these distortions can arise from procedures that are used to select subjects, factors that may influence study participation, and factors that influence participant attrition. Now, looking specifically to how selection bias plays a role in RCTs, we have to realize that in a randomized clinical trial, factors that influence participation in a study are unlikely to introduce selection bias that affects internal validity. Now, why is that? Well, it's because at the time the study starts, the outcomes haven't occurred yet. Plus, because it's a randomized trial, you're randomizing who gets which exposure. The subject is not selecting their own exposure. So the threat to selection bias from factors that influence participation are unlikely to affect internal validity. One could argue they may potentially affect external validity. However, factors associated with attrition or loss to follow-up can introduce selection bias in a randomized trial when two of the following conditions are met. The first one being that subjects who are lost to follow-up have a different probability of the outcome compared to those subjects who remain in the study. And this type of loss to follow-up differs across the two intervention groups that are being compared. So what this means is that if the losses to follow-up are simply due to random chance and they're occurring equally in the two arms that you're comparing, then that won't threaten internal validity. That might reduce your statistical power, and so you may not be able to detect a difference, which introduces maybe a random error, but it's not going to introduce selection bias. It won't bias the association you're seeing in the study. So, in order to know whether the study has selection bias or not, we're looking to see how well were the study participants followed during the study duration. And ideally, we're looking for greater than 80% of follow-up, which is considered the gold standard or considered good. Now let's talk about a third source of systematic error, and that's misclassification or information bias. And I'm going to split this up into two parts. First is errors of classification of exposure. So what do we mean by errors in classifying the exposure? Remember, in a randomized clinical trial, the exposure is whether you're on the treatment arm or the placebo arm. So misclassification would occur if somebody who's on the treatment arm stops taking the treatment and is technically now, part of the placebo group. But because we use intention to treat, we're going to keep them in that treatment arm. So as a result, in an RCT, drop-ins and drop-outs can result in misclassification of the exposure. So what's a drop-in? This is where someone from the placebo arm says, hey, they figure out they're on placebo, they want to stop that, and they want to, start the treatment. So they drop into the treatment arm. Dropouts could be an example where someone is randomized to a treatment group and they don't like the side effects or they just don't want to take the medication, and so they stop it and they've technically dropped out. What's the consequence of misclassification of exposure? Well, because we're going to use intention to treat analysis and we're going to preserve subjects in the group that they were randomized to when we analyze the data, the result of this drop in and drop out is that we bias the association towards the null. So it results in underestimation of the true effect of the intervention on the outcome. Now, how can a study minimize these errors? Well, when you can be sure that the subjects are adhering to the intervention that they've been randomized to. So as I mentioned in Module 1, blinding can help with that. If subjects don't know which treatment they're on, the placebo or the actual treatment, they're more likely to continue with the treatment. Now, similarly, we can think of errors in misclassification of the outcome. So this is where you assume, or based on the way you're ascertaining the information, that someone has actually improved when in reality they haven't, and vice versa. So as we can imagine, subjective outcomes are more likely to suffer from misclassification bias, especially when the intervention cannot be blinded, because just due to expectation, if someone knows they're getting a treatment and it's a subjective outcome, then they're more likely to say, yes, they are getting better because, they are on treatment. So how can you minimize misclassification of the outcome? Again, by blinding both the subjects and the investigators and using precise, accurate, objective measures to ascertain your outcome. So it's important to have standardized operational definitions, and you apply these definitions to all study subjects in exactly the same manner. So now let's pull in what we learned in Module 1, where we talked about the key features of randomized clinical trials and how they map to these systematic sources of bias. So we discussed that all RCTs should have a prospective design, they have an intervention, they have a placebo control, and some of the key features were randomization, blinding, and excellent follow-up of study subjects. So if we were to map it to these, three, or I guess I've split up misclassification bias, so you've got 4 different sources of systematic error here. And what are these design features that map to each of these sources of bias? So yes, confounding. The way we control for that is by using randomization in a clinical trial and using intention to treat in the analysis. How do we know that the study has good control for selection bias? Well, if they have excellent follow-up, greater than 80% in both arms, we're in good shape. What about misclassification bias? If you can blind the subjects to which intervention they're getting, they're more likely to adhere to the treatment. So if you minimize drop-in, drop-out, also known as crossover, you can minimize the misclassification due to exposure. What about misclassification of the outcome? Again, if you can blind the subjects and the investigators, have objective measures, and apply consistent criteria for all subjects, you can minimize the threat due to this bias. Now let's talk about chance variation or random error, which can also result in, your inability to either see an effect or see a spurious effect. So what do we do to minimize random error? Well, we use statistical inference to understand whether the observed results are due to chance. So yes, you all remember from your statistics days, we use tests of hypothesis testing, which gives us a p-value. So we do significance testing. And what's the p-value? It gives you a single probability, which tells you how likely is it that you're going to observe what you have found in this study or something more extreme just purely by chance. So if this p-value is really small, then, we have evidence to reject the null and conclude that, this exposure or this intervention is associated with the outcome. In parallel with hypothesis testing is the confidence interval. It gives you a sense of precision around that estimate. Some of the other aspects of random error are things like, did the study have the power to detect an association? So the power of a study is the ability to detect an effect given that an effect exists. So what we're looking for in the paper is, do the authors or researchers tell you about sample size or power estimation that was done in the design phase of the study, and perhaps, they were able to recruit the subjects that they needed to find a particular hypothesized effect estimate that captures the relationship of the intervention and the outcome. What about multiple testing? So things that you're looking for is they look at several outcomes and they test everything at the alpha of 0.05 level. Or was the interim monitoring done? And so in order to preserve the overall type 1 error rate at 5%, did they use statistical procedures that control for a false positive finding just due to chance? So in summary, what are the questions that help you think critically when you are critically appraising a randomized clinical trial? Well, as I mentioned, the initial screening questions are, what is a research question? So what was the population? What was the intervention? What were the outcomes? And was the RCT the appropriate design to answer this question? You then turn your attention to potential sources of bias that could threaten internal validity. And here I'm focusing on the systematic sources of bias: confounding, selection bias, misclassification of the exposure, and misclassification of the outcome. And finally, what are the results? So we're not done yet because, as I mentioned, and I just want to reemphasize this point, there are bound to be biases that exist. So the first piece is identifying the bias, okay? So if you think the bias exists, the next question to ask is, would this particular bias affect the results towards or away from the null? So I guess what you're asking is, as a result of this bias, are we underestimating the effect or are we potentially overestimating the relationship between the intervention and the outcome? And then what do we think is the magnitude of the bias? If it's small and if it's towards the null and you're still seeing an effect, we usually will not worry about that because it would still leave us with the inference that the exposure is associated with the outcome, or in the context of an RCT, that the intervention is having a beneficial effect on the outcome. On the other hand, if the bias is large, and particularly if it biases the results away from the null, you're worried that you may have overestimated the effect. By we, I mean the study authors and researchers, and perhaps it may be possible that this effect actually does not exist. So what I'd like you to do now is to pause or stop the video, and based on what you have learned so far about the methodologic features and how an RCT should be designed and conducted and analyzed, can you come up with a list of questions that'll help you address the internal validity question when reading an article about treatment or prevention? So do that, and we'll pick up on this when we continue Module 3, Part 1, where we will actually go through these questions.